the CPAP and BiPAP. The CPAP, that is continuous airway positive pressure, and BiPAP is a bilevel positive airway pressure. So the indication of the non-invasive ventilation, the hypoxemia refractory to the non-ventilatory oxygen devices, the mild acute respiratory distress syndrome, the facilitated ventilatory weaning. Indication of the non-invasive ventilation, the hypoxemia refractory to the non-ventilatory oxygen devices, the mild acute respiratory distress syndrome, the facilitated ventilator weaning. It prevents the need for the intubation and bridge to the intubation, and it reduces the work of breathing. So the advantages of the non-invasive ventilation: minimal risk of the exhaled air dispersion, lower the chances of the leakage, effective lowering of the work of breathing by maintaining the positive and expiratory pressure, and the helmet non-invasive ventilation reduces the mortality and decreases the need for the intubation in non-COVID-19 hypoxemic respiratory failure. The non-invasive ventilation, these are the some interfaces like the mask, nasal, oronasal, total face, pillow, mouthpiece, and the helmet, and the choices of the interfaces based on the advantages and disadvantages. Does the non-invasive ventilation help or harm the COVID-19 patients? Yeah, the non-invasive ventilation may cause the harm to the patient through the two different mechanisms. That is the which may lead to the worsening patient outcome by the lack of ability to control the tidal volume and the possible delay in intubation and mechanical ventilation. And the use of the non-invasive ventilation in patient with the acute respiratory distress syndrome has a failure rate of the 50%. Now the contraindication of the non-invasive ventilation: the uncooperative or extremely anxious patient, reduce the consciousness, inability to protect the airway, unstable cardiorespiratory status like the shock, trauma or burn involving the face, excessive secretions, vomiting, congenital malformations like the either tracheoesophageal fistula, the cleft palate, congenital diaphragmatic hernia, facial esophageal or the gastric surgery, pneumothorax with the bronchopleural fistula. So now the talk about the mechanical ventilation in COVID-19 patients. The concept of the mechanical ventilation is a useful modality for the patient who are unable to sustain the level of ventilation necessary to maintain the gas exchange functions, oxygenation and carbon dioxide elimination. And the mechanical ventilation is a technique in which the energy is supplied in a predetermined way to augment or replace the patient's muscle in performing the work of breathing. So when we switch the patient from the non-invasive ventilation to the invasive ventilation, if there is increased the drowsiness, the work of breathing, oxygen requirement, hemodynamically instability, vomiting, risk of aspiration, progressive radiographic severity, and the falling respiratory system compliance less than 40 ml per centimeter of water, increasing need of positive and expiratory pressure, that is more than 10 centimeter of water to maintain the oxygenation, and increasing the minute ventilation more than 10 liter per minute. Ventilation ventilation need in the COVID-19 patient. The possible clinical indication for the endotracheal intubation: impending airway obstruction, the signs of unsustainable work of breathing, refractory hypoxemia, hypercapnia or acidemia, encephalopathy or inadequate airway protection. The additional considerations: does the illness predict deterioration? Are difficulties in the endotracheal intubation anticipated? Is the hemodynamical instability? Will intubating now improve the safety of the patient, planned procedure or transportation? And will intubating now improve the infection control and staff safety? So the unclear whether the COVID-19 is associated with a distinct form of ARDS that would benefit from a new strategy of the mechanical ventilation. And the strategy aims to prevent the ventilator-induced lung injury by avoiding the alveolar overdistension, the hyperoxia, and the cyclical alveolar collapse. So mechanical ventilation, there are some pitfalls and problems. The potential detrimental effect associated with the positive pressure ventilation by reducing the venous return and afterload, hypotension and reduced cardiac output, barotrauma, ventilator-induced lung injury, air trapping, may increase the dead space by compressing the capillaries. The rescue therapy in the severe COVID-19 patient in prone positioning during the mechanical ventilation, if there is refractory hypoxemia, if their PaO2 FiO2 ratio less than 150 mm of mercury during the respiration and FiO2 of 0.6 despite of appropriate positive and expiratory pressure. And there is some randomized trial involving the intubating patients with the ARDS, placing the patient in the prone position for at least 16 hours per day, has improved the oxygenation and reduced the mortality. So in COVID-19 settings, we generally prefer the rapid sequence intubation, and the main purpose of the rapid sequence intubation is to avoid the positive pressure ventilation by bag and mask and minimizing the risk of aerosol spread to the care provider. And it prevents the gastric inflation in patient at risk of aspiration. So these are the 8 P's of the rapid sequence intubation. It includes the preparation by the all available equipments, the pre-oxygenation, the suction, and the pre-oxygenation at least for 100% oxygen for at least 3 minutes. The pre-treatment by some medications like the atropine, which will reduce the risk of the bradycardia during the endotracheal intubation, and the glycopyrrolate, which may reduces the secretions. The paralysis with induction, protection and positioning, the placement, and the confirm the position of the endotracheal tube, and the post-intubation care. And the minimizing the risk of exposure to COVID-19 patient by use of appropriate full PPE, inline catheter suction, that is closed suctioning, the minimized circuit disconnection, temporary clamping of the endotracheal tube before the suctioning, the passive humidification with a heat moisture exchanger filter rather than the active humidification, the viral filter in the expiratory limb of the ventilator circuit, and pre-attached viral filters in bagging circuit for use in emergency. So, the medical oxygen may be treated as an equivalent to a drug. The use of oxygen should be judicious. The devices should be selected based on the need of the patient. Each device has its limitations. The mechanical ventilation can be a double-edged sword. The intubating everyone early can be disastrous. The ventilation strategy need to be individualized. Thank you.